Welcome to AETCM, the Emergency Medicine Channel. Today, we have with us Dr. Zakaria from the Department of Nephrology, Associate Professor. And today we are going to talk about extracorporeal therapies in sepsis with AKI. Coming to the patient, a 51-year-old female was brought to the ER with complaints of cough, breathlessness and fever since 3 days. She was admitted in outside hospital where patient had an episode of desaturation. She was initially put on NIV, following which patient was intubated and mechanically ventilated in view of impending respiratory arrest. Then patient was transported to our hospital, and during transport, patient had cardiac arrest, after which she was resuscitated and ROSC was achieved within 6 minutes, and then she was rolled into our ER. On initial 10-second assessment, patient was intubated. Breathing wise, she was maintaining saturation was of 97% with 100% FiO2. Circulation BP 90/60. She was on NORAD infusion. Pulse rate was 128 per minute. Disability E1VT M1. Exposure wise, she was having a temperature of 103 at that time. We started her on injection PCM. On adjuncts to primary survey, we took an CBC-CRP point of care, an ABG and an ECG. CBC-CRP wise, her total counts were 3.6 with the hemoglobin of 11.4, platelet 233 and CRP of more than 230. ABG wise, pH was 6.99 with PCO2 of 70.6, lactate of 14.3, bicarbonate of 16.3 and creatinine of 3.37. Electrolytes were within normal range. So, ECG was showing a normal sinus tachycardia. Coming to the sample history, patient was 52-year-old female, went to the outside hospital with complaints of fever, cough, body pain, breathlessness, sore throat since 3 days. She was no complaints of any dysuria, any chest pain, any palpitations. On outside evaluation, patient's chest X-ray was showing bilateral opacities, and then patient was not allergic to any known substance. Medication-wise, she was on amlodipine and metformin, and past history of hypertension and diabetes. With this initial sample history, we come to a provisional diagnosis of patient was having bilateral pneumonia, probably ARDS. The X-ray looked like ARDS, bilateral opacities were there. She was in severe sepsis with shock. And also patient was having AKI. She was not a known CKD. Creatinine right now on our ABG shows 3.37. So we started her on, she was already on noradrenaline. We started her on BP was monitored hourly. BP was not picking up, so we added vasopressin. We started her on antibiotic and injection meropenem, linezolid, and also tafluvar was added. After that, patient's inotrope supports was hiked up because patient's BP was not picking up. She was started on injection methylprednisolone, injection eviptadil. Nephrology consult was sought in view of anuria and elevated creatinine and acidosis, which was refractory to medical measures. We were advised to start her on continuous venovenous hemodiafiltration with added oxyris. So at the same day at night, patient was initiated on the same. After around 12 hours of initiation, patient went into sudden cardiac arrest. Patient's monitor showed bradycardia, so we had to start CPR according to ACLS protocol, and we resuscitated her for around 20 minutes, but after that ROSC could not be achieved.
So you can just give just summarize the diagnosis and just a key management that you have done for the sepsis part.
Okay, sir. So patient, 52-year-old female, fever, breathlessness, and shortness of breath 3 days. outside hospital vent. Patient was desaturating, so patient was mechanically ventilated, transported to our hospital. While on transport, patient had one episode of cardiac arrest. Here, infective parameters were very high. She was in sepsis with shock. We had started her on inotrope support. She was requiring total inotrope, 3 inotropic support she was on, with patients having AKI. Her creatinine initially was 3.3. Next day it rose up to 4. Patient was anuric, and we had started her on. She was having a procal of more than 100. So we had also started her on injections in meropenem, linezolid, and also fluvid. We had also started her on injection methylprednisolone as well as injection avibtaril. Also, we had initiated her on CRRT.
So, patient was a diabetic?
Yes, sir, diabetic patient.
So you had a lady coming to you with diabetic, so basically immunosuppressed. Came to you in a state of shock syndrome. So I mean the extreme spectrum of shock where the patient was having multi-organ dysfunction. And the working diagnosis was she was having a bronchopneumonia. Fine. Okay. So normally when we don't say bilateral pneumonia, we say it's a bronchopneumonia. So bronchopneumonia, so there is sepsis, in shock, multi-organ damage. There was an AKI which was there at the time of presentation, and focus being, and now we know the focus is going to be a bronchopneumonia. So for all reason that we know, when a person presents like this, and in the background of diabetes, that is why the disease flares and they are rapidly deteriorate. And unfortunately for her, it happened that she had a cardiac instability, went into cardiac arrest, and subsequently from then it was a downfall. So you're looking at a time period of a very short period. So when we are managing, and anyway as you manage sepsis and the critical patients that come to the ER, time duration matters. And in sepsis it's even more important because maybe if you're able to catch the sepsis not only with your antibiotics and source, that's the most important thing, of course, identifying the source and treating the source, and most importantly, if it is surgical, it has to be treated. That's the control, that absolute control. And then subsequently is managing whatever happens to the body because of that state of insult that happened initially. Now, having gone through whatever you had to do in the basic, stabilized the patient, instituted your antibiotics, ventilated the patient, of fluid resuscitation, you have done all the standard therapy. But still, we know that there is a group of patients that will deteriorate, whatever you do, and this is the best practice guidelines that is there, and you have done everything. And then it's wait and watch. But over time, as the problem goes, it's when we have found out that there are ways that we can probably control the state. So why do these patients deteriorate so fast? What is?
So usually, sir, severe sepsis, usually sometimes patients go into cytokine storm. So at that moment, usually the deterioration would be very fast.
Yeah. So why all patients don't? So it doesn't happen to all patients. So obviously you cannot predict what happens to them, but with the timeline you will know. So that's our only way of predicting whether the patient is in a severe cytokine storm or a inflammatory response. I mean, the body tries to fight that infection with eliciting an immune response or an anti-inflammatory response. But there is a problem. So that itself is the reason why the definition changed. So how do you define sepsis now?
Sepsis, basically it's an organ dysfunction, sir, with dysregulated host response.
And you know what was the earlier definition?
Infection in blood, bacteria.
So there was an earlier definition of sepsis which was practiced till about the new revised one came. So the new revised one which has redefined is saying that it is an organ dysfunction, and the causative of that is going to be a immune response being dysregulated. So it is the immune system which is responsible for actually flaring up your sepsis. Of course, something must have triggered it. When there's a trigger, the body responds with your PAMs and DAMs. The trigger can be infective, non-infective. It's how the body responds to that trigger that subsequently decides what happens to the patient. Of course, the body is always trying to elicit a response protective of the body so that the person recovers, but it gets dysregulated in some group of patients, which is not predictable, but we can, to a large extent, we go with the background of saying, okay, you're immunosuppressed for some reason, you're diabetic, you have other comorbid illness, you are on immunosuppressive agents for various reasons, you are on treatment on cancer, geriatric patients. So there are various reasons where you can predict that these patients are going to rapidly deteriorate. Because the body has not responded in the way it should respond, and the immune system took a sideline or accelerated and caused the cytokine stop. So probably every patient has a cytokine surge or the inflammation, but the body is able to control it because the adaptive system works in, or by then your resistive measures have kicked in and you are able to you are able to let the storm subside. But some group deteriorate, where that's the surge. So we know it's the cytokine surge that causes this problem, be it inflammatory or non-inflammatory. So a patient of, what are the non-inflammatory causes? This is infective anyway, we know. Non-infective causes of inflammation. Pancreatitis, burns, you can have ARDS. So these are all non-inflammatory triggers, non-infective triggers. So they can also trigger a response like in the same manner of a cytokine response, because it is just a response of the body to protect you. So when that goes dysregulated, it causes a cytokine storm. So that is why definition has been changed. So it only means, of course, we are managing sepsis, but there is a gap in ourselves in how we manage the sepsis. We are able to manage the immune response. Of course, the methylprednisolone, which you had given, was always there in the guidelines, but that alone is not helping. So the only other way is to control the immune response, or what you control also would be a wrong word. You will try to modulate it, or probably you will just try to refine it in a manner that you are able to direct the immune system in the way you want, so that hyperactive state or the hyperinflammatory state gets controlled. And that is how we don't have a definite treatment. There is no single drug, okay, I give that and that gets controlled. Why? Because immune system does not work singularly. It means there is not only one cytokine that is released. There's not one, okay, this is the molecule I have to shut down. So what are the pro-inflammatory or anti-inflammatory markers that you know? The most common.
Interleukin 1, interleukin 6.
So most common we are looking at IL-6. It's one of the many. It's not that. So no one can tell you it is IL-6 that has gone up and it's not IL-10. There's no way. And as there is a pro-inflammatory, there is an anti-inflammatory also. But there is a dysregulation between both for some reason in that host, that the inflammatory markers go up, the anti-inflammatories take down, and that is what causes the damage. So as long as we don't have the drug to say that, okay, you are going to shut down that inflammatory marker, or you have a system that you're able to measure everything and say that is responsible for causing this problem, you really can't do anything. So it's only a generalized hit. You have to just try to modulate by doing something which will be a broad spectrum modality. Like you use a broad spectrum antibiotics when you do not know which is the organism. And the best thing is that we have available at the moment we know is, let's remove it from the body, because dialysis system has been in here since a very, very long time, and it has proven to be reliable, that you are able to separate components. I mean, more than dialysis, apheresis. Apheresis technology means ability to divide or separate components from the blood, be it general or non-specific. People have definitely excelled over the years, and in the last probably 10 to 20 years, significant remarkable discovery has been made, and experience also has come in time. See, all these devices were there, but it's just that the experience, cost definitely being limiting factor, and of lately it has become even more problem. Was this problem not there 10 or 20 years ago? It's not so. It was there, but what happened then was the population was different. Probably today we are seeing more deadly organisms, more resistant organisms. You have colistin, all carbapenem resistant organisms. You have increasing geriatric population, you have increasing immunosuppressed population. So you're seeing a group of population which was not there earlier. And your drugs, medicines, there is no new medicines coming in the pipeline. And that is why today's sepsis is different from what the sepsis was there several years back. It is behaving separately. Everyone has evolved. So you need something more from whatever we know. So you have this patient now. Now, how do you decide? Will come probably later at the end. How you go about, because when you are sitting in the ER or you're going to be critical care subsequently, if that's where you're going to practice, you should know when to do. See, that's the failure of the system. When should I tell? Can I do it for? You shouldn't be doing it for all. When should you tell which patient deserves it and may benefit from it rather, and how many to do, when to call it off. So there are a lot of parameters which you learn only with experience, and there is no guidelines to say this is the time, this is the time. Unfortunately the problem of this, because this is an adjuvant therapy. I always say it's something like paracetamol. You have fever, one physician may not decide to treat a fever with 101 and say, you wait and watch, let's see how it evolves. It may be an SOS medication, may not even treat at 100 or 101 and say, let me see how it goes and then decide to treat. So, but you give it to subside fevers, it's something like that. It becomes very differential, and it's on a person-to-person basis. Of course, with experience, you try to refine your level of knowledge and how you decide to use it in your practice. And mostly it is regional, or it could be hospital-based policy in which multiple departments, you have a concurrence that this is probably the best way to do it. It is not one person, there's no one guidelines to follow. It's not, someone cannot tell you, you have to use it. It's going to be very difficult. So you have the patient, so you know that immune system is dysregulated. Our only way is to modulate it. Modulate it means do something to just remove that from the body. And the best system is, so why nephrologist is because we are having the system of FRSS with us for a very long time, and we are probably excelled in that. But many places, critical care specialists, or they do it on their own because they think that can be a part of your sepsis management per se. So you have a patient, you decide what to do. So now in this, so we'll go broadly and then come back to this patient. But when you have a patient specifically with a problem, you know what to do. Now you have a patient who has non-specific problem. Patient is rapidly deteriorated in non-specific state where you have to control something with a hit with something which will cover everything broadly. And for that, you have to decide, okay, we have to do a modality, and we are deciding to support the patient with an extracorporeal support. It is just like you support the heart and lung, you support the kidney, you're supporting the immune system. Unfortunately, not with a drug, but it's again with a device. It's with a therapy. That is where extracorporeal therapy for sepsis comes. So you can broadly classify it based on a lot of parameters, how you want to take it. So some people classify specific, selective, non-selective. You can go by the type of therapy. The principle you do means, is it convection and diffusion mechanism, or you're going to do absorptive mechanism, or you're going to do plasmapheresis mechanism. So broadly, when you go into any apheresis system, or at least when the nephrologist concerns, you have on one side the hemodialysis-based therapies, which is basically works on diffusion, convection, ultrafiltration. Basically, a solute moves from a higher concentration to a lower concentration. That is applicable for cytokines also, because cytokines will move from, obviously going to be higher in the body, that will move into the onto the opposite side across the membrane, and that is discarded. That is one part. So you have that system, the hemodialysis-based system. So you have hemodialysis in that, you have hemofiltration in that, and you have something which it's the next advanced form, which is hemodiafiltration. They're all different modalities, HF, HD, and HDF. So HDF is the better form in the case of sepsis when you're looking. So just by doing dialysis, you don't get the so-called inflammatory markers removed. We use hemodiafiltration, which employs both diffusion and convection mechanism. So you have that system on one side. The next system is, what we do is plasmapheresis. So where you are only removing plasma. So you take when you circulate the blood, the plasma component is removed, the formed elements are returned back. So plasma means everything is in the plasma. And it's best done for purposes of autoimmune disorders. You have, in case of a transplant unit, when you have a rejection, we use. So you do plasmapheresis. You are removing everything in the plasma. So nothing is left behind. All the formed elements, that is RBC, WBC, and platelets is written by plasma. So obviously, cytokines are also removed in that. So that is one another mechanism system you have. And then you have the hemoperfusion system, where you pass blood through the filter. And earlier it used to be fibers or particles. Now it has become nanosorbent sorbents. So when you pass it through that, these materials have a large surface which absorbs or traps the molecules into it based on your size. So you have the hemoperfusion system. So your blood is just passing through it. It's like a sponge. It sucks them in, and then the best example is activated charcoal. Okay. And we used to be using activated charcoal filters several years back for poisoning, but now we have moved that into nanosorbent particles. So we don't use charcoal anymore. So best classical example of hemoperfusion is hemoabsorption is using particles which binds onto the surface. So that is hemoperfusion method. So you have hemodialysis and related procedures. You have plasmapheresis on one side, and you have hemoperfusion works on the basis of absorption. And then if you want, we can combine everything together. That's a hybrid form. So you have to, so when a patient comes, you have to decide which one you're going to do. Am I going to the method of dialysis, separation using plasmapheresis, and we go on to hemoperfusion. So studies have shown that the convection-based systems, there are a lot of studies, you can probably go through it, that the hemodiafiltration when you do, so these are all going to be continuous therapies. They are all continuous renal replacement. If you put them on continuous therapies and renal support, and see, they are not shown to be that promising, because to remove that much cytokine, I have to give a high volume hemodiafiltration, and results have not been as expected. So then you go to plasmapheresis. Plasmapheresis definitely has shown a promising result, but the point is, doing plasmapheresis for a patient who's in sepsis is not easy, because in a regular patient also, where we do, say a neuro patient has come with an autoimmune disorder, and you're going to do, there is hemodynamic instability, because you're removing the entire plasma. Definitely your patients are anyway severely hemocompromised, and if you are going to remove that plasma, see, we are returning back that plasma, but even as you remove, it is going to cause a dynamic shift which is going to be not good. But it does the job. So it could be the cheapest form of your therapies. In case you are pushed to the corner, that is going to be the cheapest way that you are able to tide over. There is nothing, some centers do, because you may not have a facility for doing hemoperfusion, or the patient cannot afford, because they are all expensive therapies. And you need a lot of experience to do hemoperfusion. So they might do one session of plasmapheresis for sepsis, but it is not in the top priority, and at least for us, it is never in the top priority. But it works. It is not that it doesn't work. So we do that for liver failure and all. You can do that for poisoning. So you have poisoning which are protein bound or lipid bound, we do plasmapheresis, it removes. Same principle works for poisoning. You choose which one you want, in your ER, since you're seeing a lot of poisoning. Is it water soluble, or is it lipid or protein soluble? Again, I choose all these therapies. Again, for poisoning, all these three come. Dialysis versus plasmapheresis versus hemoperfusion. It's the same spectrum. Now you're only seeing another group called sepsis. It's the same thing, and everything works in the same manner. But in the case of sepsis, plasmapheresis is volatile. In poisoning, maybe if you are in doubt, it works, because it's a generalized hit. You are able to remove everything from the plasma for the time being, to at least stabilize the patient till you have an idea what you're dealing with. It's a very safe bet to use plasmapheresis, because in case you are dealing with you don't know what you're dealing with. Is it water soluble or protein bound? Probably you don't know at that point. So if you do hemodialysis, and if it's a protein bound, then you probably would have lost. So sometimes we err on using plasmapheresis, even if you're not sure. If you're sure, that's fine. Sometimes if there's a metabolic dysfunction or a renal failure, you probably have to combine both. But we, as a dictum, probably go on with hemoperfusion plus dialysis. That's the combination. So in case of sepsis, same thing. And over time, we realize the best modality which is in place is hemoperfusion therapy for sepsis. So it's absorptive therapies in sepsis which are taken an edge over the diffusion convection method or plasmapheresis mechanism. So we go on to just absorption therapies. So that is the therapy which we will follow. So going by principle, we only stick on to absorptive therapies. So what basically absorption helps also is, you're just passing blood through that cartridge, And as you pass blood through the cartridge, it binds your cytokine and all the markers that is required. And you're passing this over a long period of time. And as time goes, the intensity of inflammatory markers that are there in the body starts to come down. So that's all what you're trying to achieve during that period of time. And why these absorptive surfaces are good, there are a lot of theories why it works. I won't go to the theory, but is because the surface area is large. So do you know what is our dialysis filter size roughly? The normal kidney filter size, normal kidney filtration surface area. Nephron, we take all the nephron together. So there is a percentage. So it's say 1 to 1.2 meters square. That's the surface area. So dialysis also works with that principle. That is why when we take our dialyzer, for dialysis, we look at the patient and decide on the surface area. Because whatever surface area that kidney has, you should be able to reproduce that in your artificial filter. Because this is not going to work. You cannot undersize it. You cannot oversize it. If you oversize, what happens is, probably there will be a hemodynamic instability. So you take it with body weight, roughly. So it's anything between 1 to 1.3 meters square of our filter size that we use for hemodialysis. But if ever I were going to do dialysis, use a dialysis method for, hemodialysis method for purpose of sepsis. It's only this 1.3 meters square, and as blood passes, the pore size has to compete with a lot of components on the blood side, which has to go to the opposite side across the filter. And it's not only going to be cytokine, which will be removed. There are a lot of other components, and it's only 1.3 meter square sized pore size filter. But once you go to hemoperfusion, depending on what we take, so if we take commonly ones which we use, if we take cytokine absorption, we use cytosorbent. Its surface area is almost as 40,000 meters square. It is several times more. You take Oxaris, which we did for this patient. It is almost close to 18,000 square feet. So it's a very large surface area that you expose the blood in a very short period of time to absorb and remove cytokine. So as soon as you pass blood, it's so large that a lot of cytokine are trapped inside in a very short period of time, because the surface area is so huge. That is why these are nanoparticles. So there is an excellent absorption which is happening in a very short fraction of time, which you require at that point of time. So that is why absorptive surfaces are much better, because very large surface area, short period of time, the best result you can get for that patient at that point of time. So now once you've decided, you decide whether selective or non-selective. So I'll just come specifically to what we do here, on generally what we do. So in this patient, we use Oxaris. Okay. So of course, principally, you have to understand whether you are dealing with a patient who is on renal failure and has a metabolic dysfunction also, or you can use a standalone therapy at all point of time. So it can be. So in case there is a renal dysfunction, because I'm discussing the case, if there's a renal dysfunction, then we decide whether I want with the renal support, or do I want to do a standalone. So you have to decide. Sometimes there is no renal dysfunction, you go for a standalone therapy. So in the case of standalone therapy, you can again choose what you want. So selective and non-selective, I mean this. So the commonly ones which we have in market at India right now, or at least what we use in this hospital, is you have Toremixin. Okay, Toremixin is a cartridge which has. You heard Tore? You're not okay. So we've probably not done it in a very long time. Toremixin is okay. So Toremixin is a cartridge which binds only endotoxin. So it's like a dialysis filter, and it has polymyxin embedded in that. Okay, so it's a polystyrene fiber. There's fibers, and you have on the surface, inner surface where the blood is in contact, has polymyxin B bound to the surface. So what it does is it binds endotoxin. So in gram-negative sepsis, the sepsis is caused by, now here we can say the cytokine responsible, or the inflammatory marker responsible for the damage is endotoxin in the case of GNB. So we are able to remove only endotoxin by using Toremixin. It binds endotoxin as you pass by, but that works only in GNB sepsis. Because endotoxin is a cause. So endotoxin is released from the organism. That endotoxin causes a cytokine surge. That cytokine surge causes the problems that we are, MODs that we are seeing. So you are removing the endotoxin here directly by using Toremixin. Then you have So this is a specific one we have. Then you have is the non-specific ones, which mainly are like cytosol, which is the most common one which we use, and internationally also it has become most common. The only one which works for cytokine, and it was more active. So we were using before COVID, but during COVID time it became very popular. It removes all cytokines. So there is no specific saying that I will remove only pro-inflammatory and not the anti-inflammatory. It will remove pro and anti-inflammatory. So that is why these are all double-edged also. So it removes generalized. It's non-specific, but it removes all your inflammatory markers in a size, post size. So it works. So inflammatory markers means it removes everything. So cytosol works with in the range of 5 to 55 kilodalton. So any molecules in that range is also removed, which means a lot of components in the body are removed, and of course your antibiotics are also removed. That happens with all our therapies. So when you're doing a patient on dialysis, your antibiotics are removed. That is why any patient on CRRT, you have to revise the antibiotics, because you must know if they are removed or not removed. CRRT means because the patient is continuously on CRRT. CRRT, it's not 2 hours or 3 hours. 2 or 3 hours is fine, because you can time your post session. If in doubt, give post. There's no problem. That's the safest bet for everything. Any expensive medicine, chemotherapy, methylprednisolone, drugs, if in doubt, always post after dialysis. That solves your problem. That is okay. That is one part. So when you do CRRT, the patient is 24 hours on it. There is no way for you to time. So it only means you have to, that is one big mistake everyone does. That if a patient is on CRRT, your dose has to be changed to a CRRT dose. So every book or any standard medication guidelines you take or which you follow has a CRRT dosage of your drug, which essentially says it has to double. That happens all the time. If that doesn't happen, it is a big problem. So it's always a big problem that people don't revise your antibiotics. Your cost will escalate. CRRT is not expensive. Like what makes it expensive is everything will double. That is the problem of CRRT therapy. Once you put, okay, antibiotics are all going to double. So that is one part. So everything is removed in any therapy that you do. And plasmapheresis will remove everything because it removes albumin with it. So it is dangerous. So that gives you more reason why not to use it. But so when you use the therapy, so cytosol also removes a range. So we have a range index which says which all drugs are removed. So we just time it. But the problem is there's nothing you can do because these therapies all run for a long period of time. But you have to learn, you should be aware and adjust your drugs accordingly. So you have cytosol. Then you have other cartridges like, so these are all company names. So I can only quote companies. So other non-specific companies, you have another company which has Jaffron. That's another company. It's not as expensive as cytosol, but it has just come into the market now. Cytosol and all, we have experience of last 20 years. At Amrita, we are using that since 2016, something like 15, 16 we are using. Pre-COVID we are using. Toray we have been using since 2012. So we have a large experience. Jaffron based has just come in off lately. So they also are another company which has cytokine binding capacity. Then you have filters. Dialysis filters. So this is the Oxalis which you spoke about. Before that, there is another filter company which makes this, which comes from the Toray company itself, called Hemofil, which is a PMMA membrane. So normally our dialysis is polystyrene, which only does diffusion or convection. PMMA membrane has a quality of having the ability to trap cytokines. So it is a absorptive cum diffusive filter. So we are using PMMA also. The only difference is all these filters are obviously expensive. Probably that is one of intermediate. So on a case-to-case basis, we will decide whether we have to use PMMA-based membrane or not. But as I told you earlier, diffusive methods are not so found to be better, found to excel over the hemoperfusion therapy. So whenever we are actually doing, you have to do it with 100% convection and hit hard. So I always, at least here, since we have been doing for so long, we only use hemoperfusion based therapy. So PMMA we really don't use. Then comes this Oxalis. Now Oxalis it's only a company. It's strictly again a company. These are all company based, and you can only use it on a single machine if you only have their company. So only if you have Prisma Flex from Baxter, you can use Oxalis. So it is basically a renal assisted device, more we say. So where you can do dialysis. You can do the absorptive surfaces. So it's basically the filter. Like I said, in TMMA has a quality. PMA membrane has a quality of its absorptive. The filter has an absorptive element to it. It's an inherent property of that filter. But in Oxaris, what they do is the surface is coated. So the surface is it's a AN69 membrane which has the ability to trap cytokines. So again, that's also a filter which has an absorptive property. And on that surface, there's a coating which helps you polyamine, which helps you bind endotoxin. And then there's a top layer of heparin, which prevents clotting, which happens in the circuit. So it's a beneficial filter in the sense it does dialysis. So inherent properties is do dialysis. It does that. It does removes cytokine. It removes endotoxin. So if you are in doubt, which one? Then I'm hitting all three together by removing. See, sometimes when we had, especially in bone marrow transplant and certain severe septicemia we have had with GI. GI problem where main organism is going to be GNB, severe sepsis and all. We use toremixin because we know it's GNB and HSL because directly you're removing the endotoxin. But when you're in doubt, very often we are going to be in doubt. We are using remove all cytokines, cytosorb. But if we are in doubt and we have no idea on which one you're dealing with, you are going to hit with all three together. So you cannot add Tore and cytosorb. That's irrational. It's not irrational. It's too expensive, and I think we are overdoing. Just give one. So in this patient, because she was anuric, she had severe acidosis, we had to decide on using a therapy which will combine everything together, which is Oxaris. It's an available filter, but that is only there if that hospital has that ability to provide able to have that infrastructure of having that machine in place. So in case you don't have that, it's fine. What we can do is, if of course you are deciding that this patient requires CRRT. So what you do is you take a CRRT machine, whichever you have, and you can add one of the filters. So if in case I didn't have this, in case in her case specifically, we didn't have the facility to do Oxaris, or the machine is being run, some other patient is utilizing it for some other purpose, we are not able to use. Then we would have decided, okay, patient needs dialysis. The form of dialysis is continuous therapy because severe hemodynamic instability. So it's going to be a long duration therapy. It's not the intermittent form. That's number one. Second, what we can do is we can add one of these cartridges to it. So we'll add cytosorb cartridge. You can add one of the, of course, we don't use the Jaffron-based cartridges. You can add toremixin. So we can couple that together. So in one circuit, we'll add both. So blood goes into the dialysis cartridge. After dialysis cartridge, it goes into the secondary filter. So it is a circuit. We'll do that and then it'll go back. So that also does the job. So you can always innovate as the case goes. So in this patient, because we had this filter was available, we combined all three together and we were not sure also. And if you are not sure, it's always cytosorb. It's always, not to be brand specific, you can use generalized cytokine removing device. At present in the market, you have cytosorb versus Jaffron. That's now there comes a stage. So that is why in this patient we decided to do Oxaris. So that's how you decide how you want. You just want a standalone therapy or you want to combine with CRT. It depends on the presence of a metabolic or a renal parameter. If there's a metabolic issue, always combine. If there is a standalone case, if this patient had hemodynamic instability also, no renal failure, you can take only cytosorb. You can decide on only toremixin or Jaffron, whichever is available. You can just do a standalone therapy. It will do the therapy. It's the same dialysis machine. It just goes in circuits to that column. And while you do that, you will see the improvement happening. So I will tell you what we are going to monitor. So you decide on your devices and base what you want. As a dictum, it is always to go for a hemoabsorption therapy, and studies have shown that is proven to benefit. You choose between what you want. You want a generalized removal or a specific one. Nowadays, we have all moved to cytokine removing devices, and we use cytosorb here. In case of renal assist, decide to use with Oxaris, which has combined everything. Now, once you have decided to do that, it's a long therapy. Now, these are all like perfusion cartridges. Now, if you do a charcoal hemoperfusion or if you do a poisoning, it's only 2 to 4 hours because it gets saturated. It gets saturated. So, likewise, these cartridges all get saturated. So, cytosorb can last anything between 12 to 24 hours. That's a maximum duration. Okay. Polymyxin is 2 to 4 hours. Jaffran also will follow the same principle of few hours to that. Oxalis, so the same thing happens. It lasts only something like 12 to 14 hours. The absorptive surface, the cytokine and endotoxin binding capacity is only 12 to 14 hours. Anything beyond that, it will not work. Okay, we have data based on that. But dialysis will happen. So again, we will think also before doing. If I feel the sepsis is severe and I have to use more intensive hemoperfusion cartridges, then I may not use Oxalis. What we'll do is we'll put on regular CRRT, keep one cytosorb, run it after 12 hours or 14 or 24 hours, change that, put one more. In the case of Oxalis, I will change that kit, which will become very expensive. So again, we decide based on that. As a dictum, we run all our cartridges anything between 12 to 24 hours. Now, how do we know it's getting exhausted or we have to change the cartridge? Is based on clinical response. So having put a patient on the therapy, first thing we look for is the hemodynamics improve. That's the first thing and foremost that we are looking for. So if you see supports start to come down, usually 6 hours you should see your supports are dropping. Usually by 24 hours, if you're early, you see supports all start to significantly recover, and by then your medicines are all working obviously. So if you see that, you know your therapy is working. Supposing you decide, okay, after your 24 hours is over, or you see how much time you're going about it, and then you decide, okay, fine, the therapy can be stopped. You got your result you want. So what result we are looking is, whatever organ dysfunction you had started it for has recovered or is showing a recovery trend, significant recovery trend. So you see a recovery and then it is plateauing. It might tell you, say in 12 hours you see a good recovery and then it stopped. You came down on supports, you were probably on 3 supports, it came down to 2 supports and then you're stuck with that. It means 2 things. It's so intensive that 12 hours it has helped you, you need to put another cartridge. So whether then you decide that, okay, I'll put a new cartridge. That's how it tells you. Or it tells you that patient is deteriorating. So normally what we do is, after 12 hours, we add one more cartridge. Or you give a break for 12 hours, see your antibiotics working, and then decide on a second cartridge. So second cartridge is always based on your clinical judgment of response for the purpose that you put. And if the patient is responding, you see your ABGs improve. If the patient had a renal failure and you only put a standalone cartridge, you see your output improving, your lactates get better, your vasopressors come down. So these are the parameters, your ventilation becomes better. So you look at your parameters. Are they getting better on your therapy? You got what you want, we try to stop away with one cartridge. If you feel the response is not at all, it is improved but got slowed down, you decide on a second cartridge, yes or no. Assuming you put a second cartridge, you got some more improvement or no improvement, then usually we call it off. We don't put a third cartridge. Okay, because it means it's extensive. There's no point in continuing further. But that's a decision we do at that point of time. Then what we do is, you start, no response at all. 6 hours, 12 hours, there's no support. It's only 2 things. It is so florid, the inflammatory response is so aggressive that probably you have to keep adding like 4 hours more cartridge, or there's no point in continuing. So probably if you have not got any response and after you put a cartridge, it means it's not working. It's extensive. So at that point of time, we usually add one more cartridge to see, because it is aggressive. It's not that it is not working. Further worsening has not happened. Your improvement has been, you're only coming to a stage of improvement, but the disease is extensive. So we may decide to add, even if there is no response, but patient has not worsened. Put one more, because probably that will, maybe with the second cartridge, something starts to happen, because the disease is so aggressive. And these are like sponge, I told you, it gets saturated. So the disease was probably so aggressive that it got saturated. And then, so when a patient comes to with severe sepsis, at that point of time also we keep in the background that sometimes the patient comes even with there is an evolving renal failure. The indication for dialysis is borderline. Whether to do with a renal assist or not, we sometimes only put a cytokine binding cartridge. So I put cytosorb, because if it is to work, as the patient starts to recover, if that is to happen, renal functions improve. So you don't have to add. As the hemodynamics improve, as the inflammatory parameters improve, patient starts to show improvement per se in the renal recovery also. So you are escaping. So it doesn't mean if there's a renal failure, I have to do a renal assist. your cytokine therapy will help the very same purpose that you expect other, because renal dysfunction is an organ dysfunction and you can add it for any organ dysfunction. So that's how you broadly go around when you have a patient. Time duration comes on how you see the response happening. Then coming is how fast to put. That was what I should have told first. So if a patient, if there's a problem in-house, 6 hours is usually the time limit these company people tell, but that's not a possible time. By the time you even realize that 6 hours, your resistive measures are just kicking in. You have to give time a benefit. So it's understood, and we all accept people who do that. You can wait up to 24 hours. 12 to 24 hours would be a reasonable time to decide on any one of the therapies that you want to do. So patient might be anuric. I might decide to dialyze. That is fine. You can add a cartridge later. That is fine. So usually you wait 24 hours is a reasonable good time to do. You have a patient coming to you. You have one support. Or maybe in the 12 hours you see a second support is going. So when you have a patient who develops another organ dysfunction to an existing organ, probably that is a time. So you have a patient, one support, definite, and the support is going up, okay, that is an indication. You have a patient who's come with, okay, it's on a support, you have a renal dysfunction level, that is a gray. So that is again a gray side saying, okay, you have to. So if you have a patient having one more organ dysfunction, think about, okay, that has also become a time to decide on your therapy. Now, what if a patient comes to the ER in case yours? That is a highly clinical decision which you take, because you do not know how early the sepsis started. You really don't know how early. In-house is fine, but outside it's a very difficult decision to make. But what happens is, as soon as the patient comes, at the earliest is what we do. We assume the patient sepsis has definitely gone undetected. So no one develops sepsis at home and crashes and comes to you. They're definitely there for some time. So as soon as the patient comes, you stabilize the patient. Then you decide, okay, let us put the patient on an aggressive form of treatment, and along with that aggressive form of treatment is going to be an extracorporeal therapy for sepsis. You keep the window very short. So what if the patient comes to you with 3 supports? So in the case of in-house hospital also, if you have a patient who comes to you with rapidly deteriorates, we really don't tell to put, because it means it's in-house. Your patient is rapidly deteriorating with an in-house bug, which is going to be very difficult to catch, and usually it will be a second or a third hit, because the patient is chronically in the hospital. It's another problem. The effect is going to be very blunted. But if you come to the ER, you are coming even with 3 supports, it is an indication, because ER is, we will take that as your index time, and assuming that you are late already, you have to decide on your therapy at the time. If the patient is even on 3 supports, full organ damage, you're not going to give benefit of time for recovery, unless if it is surgical and you have a focus staring at you. As long as the focus is not clear, in the case of surgical, nothing of this therapy is going to work. So your focus has to definitely be cleared. Focus always. So you have an abscess sitting over there, and that is your focus. If the focus is not cleared, your therapies will not work. So that is another thing. But what this therapies will tell you, until you buy time to decide on a focus, it helps you control and modulate the inflammatory response. So this will be broadly. I don't think I have to. So this is out. So you have a patient coming to you. You decide on a time zone. 12 to 24 hours a reasonable time. In the ER would be very short. Your resuscitation 3 to 6 hours. You can decide. Even the patient is on 3 supports at that time. It's never too late, because you have to just hit with whatever you have at that point of time. In the ER, directly coming. You decide on your time zone, that is fine. And after the time zone finishes, you decide which cartridge you want, with renal support, without renal support. Prefer on absorptive therapies, cytokine or cytokine binding cartridges, cytokine, which you have right now, cytosorb and Jaffron based cartridges. You decide on one of them too, whichever is readily available. Having done that, you decide your cartridge, your time duration is anything between, you see how the response goes, and it usually will last longer. It goes maximum 24 hours. Then you decide 1 or 2 cartridge. And the most important is, if you feel your parameters are not improving, definitely you call it off. Some people look at IL-6, you can look at Procal, but it doesn't really, because even if you send IL-6, you get the report after a few days. It really doesn't help you. So you can go by clinical judgment. Whatever parameter I have put it for, and usually by dictum we put down hemodynamics. And that is the first thing to improve. And it shows a remarkable improvement. So you look at, and you see your response is good, it is working. Decide on a second cartridge as it goes. So normally we do is we put one cartridge, you got a response, you wait for 24 hours, and then decide whether you want second. Very often, if you have done it on time, a good time, you have got a control. Patient will not even require the second cartridge. Company will tell you do 2 cartridge, 3 cartridge, that you don't have to follow. We have always devised our in-house way of treatment. It's a multidisciplinary. My decision is not going to be the right one always. It is we have broadly accepted that, okay, this would be the right time. This would be when you recommend the treatment and how you go about it. But no one will tell you, you should have put cytosorb over this. You should have not done oxalis, you should have done this. It's not possible. Because there is a large experience. We are definitely much better than we were 10 years back. But no one is in the position to tell you this is what you have to do. Because for one reason, you cannot tell it will work also. So it is based on your judgment, looking at the physiology and how it goes. And if in doubt, cytokine binding columns. That is it. Complications, of course, none of these therapies come with no complication. Even dialysis comes without complication. The most important problem, not a complication, is the fact that it is all very, very expensive therapies. Cytosorb will cost you, cartridge is 80,000. The oxalis is all around 70 to 80,000. Torre is 1.4 lakhs. Dafron is around 40 to 50. They're all very expensive therapy. Not the charge of the service. Now, doing the services is another cost. So definitely it is expensive. So you should be aware of all things and don't give it as an option to all patients also. Then that is the problem. What if you give this to all patients? It's not the point that it will definitely help. Why won't it help? But then that is where there's a fear that you are overdoing things. So we are still in that. We have definitely become better, but it's your gut feeling. So like we say, like in every discussion or every forum that discusses, the doctor knows it's a gut feeling. So is that the right way to go in a medical profession with a lot of evidence? It's very difficult to come to that level of evidence that you can decide on. It's practically impossible and probably unethical to do a RCT trial on this. So that anyway is not going to happen. So it is always, everyone concurs and says, it's my gut feeling. Yes, put it. It always works like that. We have done many patients here. Our experience is very, very vast because we are probably one of the earliest to do in Kerala. 2012, wide range of spectrum of diseases, and we have had very good results. Yeah, so the complication other than the cost is, which I started off with, is the fact that you have these hemoperfusion devices are like, so for maximum absorption to take place, we pass blood from down above. So usually blood passes from up down. This is from below down. So it means it will clot. Very often these patients will have a DIC or thrombocytopenia or some level of coagulopathy. So we will not be able to anticoagulate. So filter will clot off. So if it clots off, then there's going to be a problem of your cartridge, which is expensive, going. So it's not very easy, and your blood flow is going to be as low as possible. So it's a very difficult situation to handle it. But that's how we go about it, and we have never had a problem of cartridge getting clotted off, but it's always a problem. So you have to just take the patient in confidence and how we go about it. Then the problem of, if ever you give if there is a coagulopathy, all these cartridges will also cause platelet binding. So platelets will drop. And if you are doing all other therapies, dyselectrolytemia, everything happens. And to maintain this, we might give more saline so that clotting does not happen. So at the end of the result, you might see the patient might be in 3 or 4 liters positive balance because they're giving saline. So if the kidneys don't work, you have to make sure these are removed also. In that case, at the end, we add one hemofiltration. So you have to know that this therapy will cause some changes which you have to adjust or optimize your therapy so that it is taken care of. I guess. Anything else you want to ask? Yeah. Oh, it's, yeah. Okay.